Cardinal was a big help with that too. Zoe and the team, they actually have clinical people too as well that came on board last year. We reviewed our packs probably probably 3 years ago before COVID. And then afterwards, last year we had it again. And Tina came down. She's a nurse. I've had her several times that review the packs, that give suggestions as well. We found drapes that we could actually shorten the drapes a little bit. They gave cost savings there and made it more efficient as well. So it was little tidbits they were able to give to actually observe the cases and give feedback to us as well. So that helped a lot.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this vendor spotlight, we will be speaking with Elke Jackson, Director of Perioperative Services, and Amanda Lucas, Director of Quality for Perioperative Services at ECU Health. And we're going to be highlighting collaboration with Cardinal Health. ECU leverages Cardinal for all their product needs, and it's really a wide variety. It's distribution, it's pre-source packs, surgical drapes, gowns, gloves, and more. And Cardinal is their preferred manufacturer for those products and services. They even leverage RFID technology, which was an OR innovation. Today, we're going to be really highlighting their work with the pre-source team, and that's custom packs with standardization of the components that are within those packs and how they were able to do a significant reduction in their SKUs. You're also going to hear about the commitment that Amanda and Elke and their teams and really the entire organization of ECU Health and how they have this commitment to delivering quality rural healthcare. So Melanie, I'm really excited to talk about driving efficiencies and reducing waste today.
I am too. And as someone who also works in rural healthcare, I'm excited to hear how they overcame their challenges and were able to collaborate and work together to provide that efficient care.
That's a great point. Collaboration is a key theme in this success story that we'll be highlighting in just a few minutes. Stay with us. We'll be back with Elke and Amanda.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Elke Jackson, Director of Perioperative Services, and Amanda Lucas, Director of Quality for Perioperative Services with ECU Health. And I want to welcome you both to the First Case podcast. Thanks so much for coming on. Elke, we'll start with you. Why don't you introduce yourself and tell us a little bit about your role at ECU?
Sure. Thank you, Justin. My name is Elke Jackson. I am the OR director here at ECU Health Medical Center. I oversee the OR here with 23 operating rooms on the main side here.
And Amanda, if you would like to introduce yourself to the audience as well.
Thanks. I'm Amanda Lucas. I am the Director of Quality for Perioperative Services at ECU Health Medical Center, as well as I oversee our ERAS, bariatrics, sterile processing, and the ancillary departments that help Periop run here at the medical center.
So, as we prepared for this interview, one of the things that we talked about was just the commitment that ECU Health has to serving the community. And I know both of you really have that sense of mission that's connected to that. And so I was hoping that maybe you could talk a little bit about just ECU Health and how you are, serving the community and maybe a little bit differently than other health systems.
Yeah, so here at ECU Health Medical Center, we are an academic health center. We have around 1,700 academic beds, and we service 29 eastern counties in North Carolina, which is really important because we service those counties. They're east of 95, how we call it, and this is really rural health. So we're dealing with populations who don't really see the care that they need, so they're very sick. And so at our facility, we're a level 1 trauma, which is really great because they get access to robotic surgeries, things that you see up in the triangle, but you wouldn't necessarily think in rural health that they'd have access to it. As well as we are partnered with our Maynard Children's Hospital. So we also have that facility with our NICU, PICU, as well as the teaching hospital with ECU Health Brody School of Medicine. So just a really great place to be. You would not think east of 95 in this rural county that we would have this big resource here. So it's pretty amazing, and trying to make sure that this center kind of gets put on the map because we do a lot of great work with little resources compared to other level 1 trauma centers.
I also know that you're connected to the university as well. And so, how much does education and just being involved with teaching impact, kind of like you said, more with less resources? You have a lot of resources academically as well, though, correct?
We do. So there's a lot of research here. Dr. Pori's, for example, in diabetes has been really pronounced. Dr. Diamaria, who is now one of our chiefs, is very highly involved in bariatric surgery. So the education brings people here from various places, like we have New York, Ohio, to try to compete with Johns Hopkins, for example, as a primary one. And so we bring them here, and then when they come and see our facility and what we can offer, they're like, wow, you guys do pretty much similar what we can do other places. And what's really great about it is because we are rural, the cost of living is a little bit less. So you can actually get more for your buck here, but you're still accessing the same technology you would up in New York, for example.
That's great. And Elke, maybe you could tell us a little bit more about the operating room. What kind of volume are you doing? What kind of procedures are you doing? Maybe give us a little background there.
Sure. So here in the main OR, we have 23 operating rooms, and we average around 75 to 80 cases a day. What makes us unique, as Amanda was saying, we have both the academic surgeons as well as our private surgeons. We also have a vast variety of procedures which cross over many service lines. The service lines that we cover in the main OR are general service line, the trauma, the pediatric, neuro, ENT, dental, ophthalmology, ortho, podiatry cases. We also do plastics, oncology, transplant, which we actually have done over 150 transplants just this year, kidney transplants, that is. And we also do some pancreas transplants as well. We also have GYN, urology, and robotic surgery. And just this past year, we got our accreditation for the Center of Excellence for our robotics and our MIS program. So there is a wide variety of surgeons that we have here over the service lines, and which also helps bring in our residents, and it gives them a great learning experience for them as well. So each year we have averaged a 4% increase in our volume. So we're still moving up as we go, which has also allowed us to get 2 CONs for another additional 2 more rooms for this coming up year. So we look forward to that as well.
So one area I wanted to highlight before we kind of talk about maybe some challenges that you've been facing since COVID, and I'm sure that our listeners that it will resonate with them, that they face some very similar challenges. But addressing social issues is something that you mentioned to us previously was very important to ECU, and that you're really on the forefront of addressing some of those social issues that affect quality, of health and life in general. Do you want to talk about that?
Yeah, so the social issues here, economically, we're dealing with the lower tier. We deal with people who do not have primary care providers, and sometimes they report to our DED, and we are their primary care. And so ECU Health has done a lot with trying to open clinics, and the merger with ECU, and we also had VMG groups, private providers. They're trying to get it all-encompassing so we can actually make sure they get that primary care so they're not flooding our EDs, because as everyone knows, ED volumes are extremely high and people can't afford health insurance. So instead of clogging up the EDs, they are really trying to look at what practices need to be expanded, as well as we know for mental health and behavioral health here is a huge thing. So they're actually building a huge center here, which is going to help all the people here who don't have access to that, and also help facilitate taking care of patients closer to home instead of shipping them farther where families can't visit them. We know how important it is to have that support structure. So ECU Health is really looking at the socioeconomic. And honestly, when we're operating on patients, we are not getting the walkie-talkie healthy 34-year-olds coming in. We're getting the 57 COPD, asthma, diabetic, hypertensive patient who's coming here who hasn't seen a primary care in like several months. So really important to kind of address that. And ECU Health as a whole realizes that and understands that sometimes our length of stay is going to be higher because we're dealing with patients who are sicker. And so when you look at reimbursement and things that they're doing in healthcare, that's why Dr. Waldron and Brian Floyd are really adamant on getting us resources, because we're trying to take care of patients who are sicker, don't have the resources, and quite frankly, don't have the background to get that primary prevention in place.
I don't know if Melanie even knows this, but early on in my nursing career, I worked in mental health and I ran a wellness program. And I cannot emphasize more what you just said about the importance of serving the community in those two areas. It's often services that are highly underutilized. And if you want to influence the cost of healthcare, you really have to focus in those two areas. So I just want to commend you for that. And it's something that I've seen firsthand in my prior experience, like what the challenges are to getting, everybody in the community engaged and removing some of the stigmas around it that can really help with improving, their health. So that's great to hear. All right. Well, speaking of challenges to health, COVID was a pretty big challenge. And I'd like to just talk about maybe some of the things that you all had to go through, and then how did you navigate that? So maybe just start there.
So, COVID hit with a bang, and we all know that. And in the OR, especially we're dealing with airways. So we are right there at the forefront. Everybody's freaked out, don't know what to do. So just finding those protocols and how to take care of those patients was our number one priority. But then as you saw the issues with supply chain, people were stopping making certain products, focused on PPE, and we're like, hey, we still need that tubing. And they're like, well, we're making masks now. And we figured out we're not going to get what we need. And so trying to find backups, get allocation was very hard. We partner with Cardinal Health, which is great. So we have a distribution center. We do have people on site here that we can consult with, but it was slim pickings for a little while. And also one of the challenges we have here at ECU Health is we are a very big organization, but we are the largest ranch style hospital. We are spread out wide, not tall. So our SPD from our main OR is probably about 2 football fields away. We actually have a trolley that brings all the supplies here. So one thing that we noticed with efficiencies, we got to work with what we got, but how can we be more efficient? And Elke and I were tasked with trying to figure those things out, along with trying to care for COVID patients. So not overwhelmed at all. Don't carry many hats like most people do. And anyone who works in the OR knows, we just sit there and just watch, things happen. So when we looked at it, talked to the staff, we realized we had supplies everywhere. We had, this tubing in 7 different places. Some things would go expired. We didn't know where to find it. When we have cases, just like when you bake a sheet of cookies, there's a recipe sheet. We have pick lists for each case, and it tells us exactly what we need to do that surgery. And so what we noticed is the locations for them were all wrong. There was no locations, or the product just didn't exist. And we didn't know that because no one had cleaned up the preference cards, or it was in PeopleSoft underneath a different name and the systems didn't talk. So we went on this big, long project, and it took us about a good full 2 years to do it. But we partnered with our supply chain here, and what we did is we kind of streamlined where it was located. So if we picked it for 80% or above on most cases, it went down to SPD and was picked there. And once that pick happened, we would come up to the OR where they would keep some of our backup, but they kept the more readily available, what we need in a pinch and trauma, and those specialty items like trachs or things like that are more patient specific. And so we did a lot of work with that. And in doing that, I have worked in Periop for 8 years, but I am not an OR nurse by trade, which they don't let you forget if anyone works in the OR. So when they would say things to me like, I need a fish or I need this, I'd be like, I have no clue what you're talking about. And a prime example is like, I need the short tubing. And I'd be like, the 451? They're like, the short tubing. I'd be like, oh my gosh. Okay. So realizing the name and the nomenclature and the difference was another big thing that we tried to figure out. So what we did is we created stations for our supplies down in SPD because SPD are not clinical. They are high school graduates. They learn how to clean the instruments, but never set foot sometimes in the OR. So we tried to streamline it where it helps. So we created like Packland, you have Drape Island, you have your whole robotic area. So at least if they were like, I need a drape, you can go there, and sometimes they'll pick several and send them up. So we did a lot of those things on there. And I know Elke up here did a lot as well to kind of help with that.
Yeah. And setups here, we kind of did the same thing they did down in SPD or the case pick area there. We kind of sectioned stuff off as far as also the service lines. Because if you needed something for neuro, you kind of would go to the neuro section. If it was for ENT, we put all the blades together for like all the ortho and podiatry or plastics would need. So it's all in one area along with the burrs. Something that simplified for the staff.
So I'm curious, you mentioned, Amanda, that your SPD is like 2 football fields away from your operating room. And being an OR nurse myself, I am always afraid I'm not going to have what I need, or what I need when I need it is not going to be available. And I'm curious, Elke and Amanda, how did you handle the natural tendency of OR people to hoard and to squirrel things away so that they would have it if they needed it? And instead of that, getting them to trust your setup and trust your system so that you could have it when they needed it, but you weren't having piles of things hidden in places where you couldn't keep up with.
Correct. Yeah, it does. Sense? It's understandable because when we did move away, we had a lot of, if you logistically in our OR here, facility here, we had a Pixas at that time. And with the storage system that we have now and working with our IT department and materials, and we set up stuff, the new shelving that we had actually accommodated a lot more supplies that we were able to keep actually just in setups. And we keep the emergent kind of stuff outside the rooms. We have certain carts for the emergent kind of stuff like you're referring to. As far as in setups, though, they're more easily, readily, like I said, available closer to us. She keeps a lot of the Amanda in central / SPD keeps it more so for the big bulk items and the stuff that wasn't more urgently needed. And if there was items that were like we considered urgently needed, we did have like a sort, we'd have one kept up here, 1 or 2 of those kept up here in a par level instead of just a regular inventory. So that does assist on that too as well. So there's a couple shelves in there that we consider the par levels so that the staff would still be able to ready available and wouldn't have to wait for her staff to bring it up.
Yeah. And one of the things is SPD and OR don't really mesh very well. They are always at each other's throats. It's always the other person's faults.
Oh, yeah,
and
absolutely.
So we've tried to really foster the team atmosphere. We're still working on it. It's been a couple of years, but we're making a little bit of progress. But like Elke said, we had carts up here. So if it was down in SPD, there is backup up here. And it did take us, I want to say, Elke, correct me if I'm wrong, probably a good year when we implemented this new system to get people to buy in because, of course, everyone was like, this is never going to work. It's going to fail. And we just kept pushing through and we're like, well, we got to do something. It's better than what we have. And I think finally it's been about probably 4 years now, Elke, with the system. People are finally settled into it. So when you talk about change in healthcare, it is not immediate. And to change a culture takes a long time and you got to get buy-in. And to the point now where the surgeons were even skeptical, and now we even got a compliment. I think Elke and I almost fainted that it's way better than what you used to be, and just wasn't used to.
Okay, so actually you hit on a big issue because our culture and our natural tendency to hang on to the way we've always done it, even if the way we've always done it doesn't work. This is how we've always done it. And so this is our sacred cow. And by God, we're going to worship it, right? So when you change the system and you actually implemented a new program, a new way of doing things, you said you had to get buy-in. But how did you get that buy-in so that people would get on board?
We actually had meetings. We met with our supervisors and our lead techs were involved. We had input from them as well. And we also, when we talked about it, we actually came in with a standardized room restock for each of our rooms so that all of them were alike. And so we had buy-in from the staff. We actually had staff input as well. So that was one thing that did help. I mean, yes, we still had minute resistance, but we did try to involve the staff so that they would actually have buy-in as well.
Oh, yeah.
Yeah,
Excellent.
We put it back on them and we were like, we need you to design this. We will figure out how to implement it. But the stuff that Elke keeps in our cores, what's kept in setups, they all had buy-in into it. So we said, it's not Elke and I failing. It's not us failing. It's all of us because we're all inputting it. And to what Elke said, we're always going to get naysayers, but you got to persevere. And it was hard, but now I think that they're finally accepting it and it works. It works a lot better than what we were, especially when we're pushing 90 cases.
To change culture, it takes a lot of small wins over time. And one of the things that I think with this project that you're referencing, and it's really several of them, the big picture was how do we change the culture? But the small projects along the way, it's about sharing in that success and being able to measure that and say, hey, here's what we accomplished together. You kind of start to create some of that unity. How did you measure success as you were trying to create some of these efficiencies that ultimately led to the surgeon feedback that you recently received?
So I know one thing for us is when we talked about where all the supplies were located and, cost is big, right? And so everybody wants different things. Staff want newer things. So do the surgeons. So when we did the whole inventory revamp, we had over 4,000 SKUs and we reduced it around to 2,000. So we did a lot of reduction, which was very helpful because, that's money on the shelf that potentially could die on the shelf. And they're not going to give us any more resources if we're continuously to waste that. In addition, we also worked with Cardinal on our PACS program, and Elke does a great job with reviewing that with our vendor, Zoe Weber, who is one of our people that helps us. And so we try to eliminate how many items they're physically opening at the field. If you can put it in the pack and you can get it where you open this big thing and you can just kind of do it. It's less things they have to open. They know they have it there. As well as we also found some cost savings that we had items in packs that were way expensive to have in our packs. We actually took it out. But trying to streamline those things and having those wins, making it easier for them to open a case is very important, especially here at our facility and with traumas and things like that. Or if you get floated to a service you're not really too familiar with, at least the pack has majority of the stuff that you need for the case.
That is such an important point, that last one.
Oh, yeah. And I think one of my favorite things about customized packs and having packs that are uniquely designed for your cases is how easy it is to open your room, how easy it is to get the case open, and how quickly you can do it. The current facility that I'm working in now does not have that. And so we are opening every single item for our cases, and it drives me nuts. I mean, every individual drape, everything. And the previous facility I was in, we had, packs for different kinds of cases, and you open it up and most of it's there. And then you just open the surgeon specific stuff and off you go. And so much faster to set up. Your stuff's there. And like you said, if I don't work with that surgeon all the time, or I'm not always in that service, at least everything that pretty much is going to be there. So I'm not worried that I'm forgetting something. So I absolutely love the additional peace of mind that comes with those packs because everything's there and it makes it so much quicker.
Yeah,
I love it.
Cardinal was a big help with that too. Zoe and the team, they actually have clinical people too as well that came on board last year. We reviewed our packs probably probably 3 years ago before COVID. And then afterwards, last year, we had it again. And Tina came down. She's a nurse. I've had her several times that review the packs, that give suggestions as well. We found drapes that we could actually shorten the drapes a little bit. They gave cost savings there and made it more efficient as well. So it was little tidbits they were able to give to actually observe the cases and give feedback to us as well. So that helped a lot.
You talked about the dynamic between sterile processing and the operating room, but a similar one can exist between supply chain and the operating room. And so we didn't really highlight that, but what I love about this story is I'm sure that you got a different appreciation for supply chain and vice versa by going through a project where you're looking at utilization, you're looking at standardization. Those SKU reduction had to make everybody in supply chain really happy. I mean, that's something that they look at all the time. And, I want to commend you for stretching out into that department as well. And then you talked about the surgeons and how you got this positive feedback. I think sometimes one of the hard things is they're so busy. People don't realize just how much you have to curate the information that you're going to put in front of them. And it has to be very specific and it has to be credible. And to get surgeons to sort of understand the finances, a lot of times people are like, oh, they don't care. That's not the case at all. But we're often not giving them the information in a way that impacts change for them and giving them that transparency. And something that you told us about in preparation were case receipts, where that really helped not only drive change with the surgeons, but just help them have better awareness without taking a lot of their time. Can you talk about that?
Anyone who works with a surgeon, they're a little bit competitive. So if you can show them that, hey, this person's quicker and cheaper and has same quality outcomes, it kind of grabs their attention a little bit. So,
or their jealousy or that competitive streak gets something.
And, it's nice. So we utilize Power BI here, where we flow in tons of reports from Epic as well as our supply chain. And we also from different databases like our Clarity, Caboodle, things like that. And part of that's the case receipt, right? So we're able to show that in service line meetings. But the case receipt is really important because at the end of the case, it will show you exactly what it is. So just like the surgeons, sometimes, circulators in the room might not say, hey, I wasted that, so it shouldn't be charged to the patient. If they don't pay attention or do that, then the case receipt's off. So your cost is up. And so the surgeons were like, okay, whatever. When we started to show them that, at the end of the case, they'd be like, no, wait, I didn't use that. Or at the beginning of the case, they'd be like, wait, hold that. Don't open it unless I ask for it. And then also, too, things with staplers, because different products are way more expensive. This one stapler could be $3,000. This one's $500. And they're like, why is my case higher? And we show them that. And they're like, oh, I didn't know that costs that much. And we're like, we tried to tell you.
Yeah. You didn't listen. Oh, yeah. I've run into that so many times just with I guess I should admit that as a circulator, as the person charting the case, I don't always go back and actually remember to mark what was wasted or what wasn't used because you get flustered, things get busy. And so being reminded that every single detail in our charting and in what we're documenting matters because when we can see it at the end of the case, hey, we really did use this, we really didn't, and keeping track of that and being able to keep our costs down while still providing excellent patient care, that really is a win for everybody in the system and our patients. And really remembering how it's all connected is very important.
So, we're coming to the end of the interview, but I'd like to talk maybe a little bit about best practices, and either of you or both of you can chime in on this. But if somebody else is listening to this podcast and they're looking to drive some efficiencies and identify savings opportunities, you've definitely detailed some best practices, I think, in just telling your story. But are there either one that you just think is really critical, or maybe one that we didn't explicitly cover, in the discussion so far that people should really take away from this and continue to kind of drive, their care delivery and their fiscal responsibility forward so that they can invest in the types of innovations that just continue to improve care to their communities?
So I think one of the best practices is always to think about efficiency and how you can make it easiest for your staff. So, getting packs in place is a best practice and essential, but also making sure your preference cards are up to date and that you have everything that you need and it's accurate on there, as well as working with your supply chain to identify subs, and having that clear communication is really the essential thing when you're talking about an OR room and setting it up and making sure they have everything they need, even if you have it as a hold on there. So if you think you're going to need it, put it on the preference card. At least it's in the room and they don't have to run out and get it.
And Elke, do you have anything to add there on some best practices?
Just look at everything as a whole. I know we kind of discussed that, but, look at your whole inventory. And, we also looked at items. I'll pick on suture, for instance. We had 3 different SKUs, but do you really need all 3 different sizes? Can you just use the 18-inch, 24, and 36, or can you do away with the 18, or can you do away with the 24-inch and just go with the 18 and say the 36-inch length and thread there? So that's just one particular example I'm giving, but as a whole, and then to see, if you do have an SPD or central location, like, we're having to go the football length to go get to, as look at what you have in both areas and can you consolidate to one area efficiently? That was our we were able to reduce, I think, Amanda, correct me if I'm not wrong, it was at least how many SKUs we went down? I think 1,800 SKUs, or was it?
Yeah, it was close to about 2,000 SKUs, somewhere in there.
So it was a big reduction. So,
yeah, that's awesome.
That's significant.
And then look at utilization was another thing that we did look at. We looked at, if you haven't used this, and there were some things that we still had to keep. You haven't used it within the last year or two. Then we reached out and we worked with the service line chiefs. Is this something that we can eliminate? And then we also went to looking at items that, instead of having this in-house, is this something that we could put on consignment instead of ordering it and then it expiring? So there was a lot of supplies that we did that with as well.
What I'm hearing a lot about is collaboration and not operating in silos, which is really, it's those types of partnerships that I think can be transformative in healthcare. And even as we started our discussion, we talked a lot about, bigger picture goals for ECU Health. So I wondered, as we tie this up maybe in a bow at the end of the interview, did you see that this, project on this kind of micro scale of detail that we've been discussing influenced or contributed to some of that bigger mission that you have in your organization?
I definitely feel it's more collaboration that we have really worked really hard the last 2 or 3 years with actually working more closely with materials, because it was a world that, that I, didn't work with every day. So we work a lot closer. They come to our service line meetings when they're needed as ad hoc. And the same thing with IT if we're needed. Amanda, I know, worked closely with IT and her side when we went to this new project as well.
Yeah, and I think it comes back to our mission, right? We're trying to provide the best care in a rural health environment. And so if we can lower the costs and streamline it for our patients, that's really the end goal. And I think we achieved that. But also, too, I think we brought a shining light to the OR that we are a hub and we're not like most units. I grew up on ICUs and IUs. I've seen operations. I had no clue how involved we have to be with contracts and supplies like you do here. And I think these projects showed not just us, but our upper leadership, the amount of resources and attention that you need in your ORs to help drive the care. Because at the end of the day, the ORs help generate the revenue to provide those ancillary services that we need for our rural health population.
I think that summed it up perfectly. The two of you have absolutely been a pleasure to speak with today. And I just want to thank you for providing a lot of detail. I feel like, just this conversation can be a great resource to others out there that are looking at ways that they can drive efficiencies and, to your point, be fiscally responsible to the communities that they serve. So I really enjoyed this, and I want to thank you both for coming on and give you an opportunity for any final thoughts if you have any. But Elke, thanks so much. Great insights today.
Enjoyed it. Thank you, Justin.
Yeah, thank you guys so much.
That was Elke Jackson, Director of Perioperative Services, and Amanda Lucas, Director of Quality for Perioperative Services at ECU Health. We highlighted a pretty significant success story. Melanie, you heard me asking, how did you measure success? Well, that's reduced SKUs from 4,000 to 2,000. That's a 50% reduction. And they went from picking 60 to 70 items per case, and were able to reduce that significantly as well by creating these custom packs and standardizing the components within. So I also really loved, we didn't get to talk about this, but I think it was Drape Island and Packland. I absolutely loved that. I thought, what a creative way to just help, kind of get everybody understanding culturally, like what the initiative is and how they are driving these efficiencies.
Oh, yeah. No, I wish we had kind of talked about that a little bit more. I kind of feel like I'm walking into the supply room, but I'm going to a theme park, right? And I'm going to go to Drape Island, but at least I know that all of my drapes are over there. So if I'm in a hurry and I'm running in to look for something, having things consolidated all in one location, where you can find it, makes it faster, gets you in, gets you out, and doesn't add to your frustration of your day. So really thought that was a unique way to name different locations so people could find things. But the overall picture of being creative, working together to find ways to make things more efficient and to streamline processes. It's fantastic work that they did.
Such a great story today. And they definitely provided a lot of details around the success that they've been having in their collaboration with the Cardinal Health team, including both their reps and their clinician, helping to streamline these processes in the operating room. We do want to let everybody know that you can reach out to Cardinal Health Pre-Source for a PAC program review or additional solutions to help drive efficiencies and innovation in the OR. And the best way to do that, reach out to customer service and get connected with your local representative. That's going to do it for this Vendor Spotlight. And on behalf of Melanie and myself, thank you for listening to this Vendor Spotlight on First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.